for rapid evidence for decision making during the COVID-19 pandemic. We are so excited to have you here with us. With me, I have Prof. Renee English, Prof. Lizardo Plessis, and Dr. Michael McCall, all from the Department of Global Health at Stellenbosch University. And today they are going to be sharing some of their experiences regarding working across academic departments around issues of nutrition and how rapid reviews can be used in the evidence synthesis ecosystem. So I am going to give the floor straight over to our presenters in the interest of time. If you have any questions, please feel free to pop them into the chat box on the side, and we will save them for the end of the webinar. I would please like to ask that you switch off your mics and your videos so that we can save some bandwidth, especially for those having internet and connectivity issues. And then also to remember that this session will be recorded. We will have some polls in the middle of the day, and we will give you the instructions on how to do that. And then Tracy Naidu, who is the administrator and set all of this up wonderfully, is going to share an evaluation with us at the end of the webinar. Any questions, concerns, comments, again, please pop them into the chat box. We will be live tweeting from this event. I will put the user handle, or Nazrin or Tracy, can you pop that into the chat? It's at CEBHC, and you can follow us there or on Facebook, on our Facebook page. The first speaker I would like to introduce is Prof. Renee English. She is a medical doctor and public health medicine specialist and holds a doctorate degree. She has experience in clinical and health systems research and in the development of responsive and innovative health system solutions. She developed the first syndromic respiratory guideline in South Africa, then called the Practical Approach to Lung Health in South Africa, which has subsequently been expanded into the PAC guideline. She was the head of the Health Systems Research Unit at the Health Systems Trust and has served as a co-editor for the South African Health Review and District Health Barometer publications. She was a past fellow of the Africa Science Leadership Program and is currently the head of the Health Systems and Public Health Division in the Department of Global Health in the Faculty of Medicine and Health Sciences at Stellenbosch University. She served on the South African Health Ministerial Task Team for Human Resources for Health and was the chair of the Information Monitoring and Evaluation Workstream. She has served on the South African Lancet National Commission on High Quality Health Systems, and we are so excited to hear from her today about boundary spanning across the academic departments during the time of crisis. Prof. Renee English, I hand the floor over to you.
Great, thank you very much. I hope you can all see me. I'm going to share my presentation and I will put that into display mode. So just allow me a minute or two to just sort out my screens. Thank you very much. So just a word of thanks to the webinar organizers for inviting me to be a speaker today. As indicated earlier, my topic is called Boundary Spanning Across Academic Disciplines. Academic departments during times of crisis. And before I start, I'd like to acknowledge those who were part of the project, and you're able to see their names on the slides, and they are listed as co-authors. And the acknowledgement also serves as a reminder that in health we achieve through teamwork, and the team is always larger than the individual. So the focus of this discussion is to talk about the daily research summaries which are completed for ICU staff working at Tygerberg Hospital during South Africa's first COVID-19 wave. There's of course much to say about this initiative, but I'll try to focus the presentation and won't go into details regarding many aspects of the process given today's time limitations. The overview of the presentations as follows. I will reflect on some of the key timelines and activities of the initiative, and then briefly provide an overview of the daily briefs, present the key developers and contributors. I'll talk about a spin-off of this project, and then we'll reflect on some key lessons learned. So I will present our journey in the form of a timeline initially. So the first COVID-19 case in South Africa was reported on the 5th of March last year. And as you know, that time was filled with great uncertainty regarding the virus, regarding treatment options and strategies, and our television screens were bombarded with pictures of scores of people dying in Italy and elsewhere. And there was a distinct sense of fear and dread as health services were preparing for the worst. Yet at the same time, many were mobilized by a sense of we have to do something. And I'm sure you would concur that it was this sense of we have to do something, which is what motivated many of us to offer assistance within the spaces we find ourselves in at the time. So our division hosted a seminar on COVID-19, and one of the speakers was Dr. Yankee Talliart, an infectious disease medicine specialist at Tygerberg Hospital. And after the meeting, I just sent him a message offering public health assistance. And that then led me to Professor Brian Allwood, a pulmonologist working at Tygerberg Hospital, who amongst other things said that it would be very good if clinicians, particularly clinicians working within ICU, could get daily summaries of the latest literature. And as you can imagine, PubMed searches at the time yielded very little empirical data or even primary research. And so after receiving a template from Brian, I went about putting together the first brief, and it was literally just something done on the fly, done very quickly. And at the same time, the undergraduate students were reorganizing themselves, given that the academic program had been temporarily halted, and they were volunteering to engage in various activities. So I spoke with two of the students who had previously shown a keen interest in global and public health prior to the onset of the pandemic, and they expressed an interest in participating in these daily briefs. And they then co-opted other students to participate. So the very first brief and subsequent briefs were posted on an initially daily basis on a WhatsApp group that was formed specifically for Stellenbosch University and Tygerberg staff. And it coincidentally, that WhatsApp group is still active and comprises 36 staff within the faculty and within the hospital. And it was quite intentional throughout to keep the group small, to limit it to clinicians, researchers, and academics working within those two environments, and to also use that as a platform to discuss matters that were of importance. In terms of the actual briefs, in time, another volunteer, Elizabeth Marsdorp, ended up becoming a pivotal person in the entire initiative, and she came on board and eventually led the development of the briefs, provided oversight to the students as I went back to my usual duties as the pandemic unfolded. And I was really then in the background of this initiative. And the last brief was posted on the 19th of August. So here is a screenshot of the very first daily brief. As you can see, we had a basic cover page. We provided an overview of the content. It gave an update of the world and South African data, and then presented key findings from the papers we identified. And it was literally done according to specification, the request that we received from Brian. It's also important to note that there were, of course, no systematic reviews at the time, and most publications were available as preprints. There were no peer-reviewed articles, a few peer-reviewed articles initially, and so this made the initial search and choice both easy but also challenging. So initially we just presented PowerPoint slides, which we posted in the WhatsApp groups, and these were just plain, simple overviews of voiceovers of the slides. We then received feedback from the clinicians to say, can you please create separate voice notes and slides, for example, and that just shows the team's commitment to be agile and responsive. And I suppose I could write a book on that entire experience, how the learning curve that went with it, how it prepared me for just online teaching material development. But the feedback was the clinicians often didn't have time to read the slides, and some of them listened to the voice notes on their way to work, etc., or used it as they were going about their clinical work. And that's just an example of how we use technology and our approach evolved over time. So here are the members of the development team. Sergio and Nonto are medical students, or were medical students at the time. Sergio is in his final year, he still is one. Nonto is doing her internship. And Elisna was a PhD student at the time and has subsequently graduated. And I do again want to state the importance of teamwork here. And Sergio and Nonto, as medical students, were amazing at rallying their own team of students from different disciplines, both from under and postgraduate years. They organized schedules for producing the briefs. They managed the process and showed great leadership. And Elisna also brought in other experts to participate in the development of the briefs. Here's a picture of the students some of the students who participated in the initiative, and it was featured in the university newsletter. It's important to note that every single activity happened virtually. There are some of these students that I've never met in person and wouldn't even be able to recognize on campus, and that attests the ability to be able to do this kind of work in a virtual way. The initiative also provided an opportunity to build the students' capacity in terms of evidence-based medicine. And as time went by and the volume of literature grew exponentially, the team then transitioned from merely summarizing what was in the literature to having to distill good quality research from amongst the exponentially increasing publications available online. So Prof. Young and her team led some sessions where the students were better equipped to identify good quality research. Importantly, the daily ICU briefs resulted in widespread faculty and hospital participation. We started to receive requests from some academics to contribute towards the briefs. As knowledge emerged or specialized papers were published, we approached disciplinary experts to assist with the reviews. We had reviews done from ethics, immunology, pharmacology staff, for example. We were also astounded at the reach, bearing in mind that the only place that we posted these briefs were on the 36-membered WhatsApp group. We never posted it anywhere else. And we received reports that the briefs were read as far afield as the United States of America, Ministerial Advisory Committee, and even within the Vice Rector's office. It was also disseminated through the Western Cape and the country and private sector. And in all, the briefs were well received we still get the occasional email asking if we can resurrect the daily briefs. There were some other spin-offs as well. We applied for funding for the 2 medical students to conduct research on the initiative, and this is still a work in progress. And I don't want to steal the students' thunder, but some prelim results show that the briefs seem to have had a positive impact on improving management of patients with COVID-19 in terms of the clinicians' responses. So about 70% of clinicians had indicated that they found the content of the briefs beneficial in their practice. The students themselves who participated felt that given that they could not be in the wards at the time or on the platform clinically, the briefs signified an alternate means of being able to support the clinicians in the field. Of the 35 briefs that they analyzed, they recorded that 115 topics were covered and 26 people, including student volunteers, general clinicians, and volunteers, had contributed towards it. Their research also shows that there is a need for data-driven research that is accurate and that is relevant, and that there are innovative ways in which we can assist those on the front lines while working in non-clinical spaces. So I'm mindful of the time, so I'll start rounding up now, but I do want to start the next section saying that extraordinary times call for extraordinary measures. And we saw a need to be filled and we stepped in to help. And I think that really defines what we as public health did at a time when we could see that the clinicians really needed some assistance. So the important lessons, what are they? The first is that the pandemic and the uncertainty associated with it garnered a deep spirit of we are all in this together. And this in turn led to a spirit of volunteerism. It was these acts of volunteerism that in itself created opportunity and value. The second is that the novel nature of the pandemic was defined by an information gap or vacuum. And this raises questions of how do we prepare to be responsive? Should we ever be faced with such a situation again? Questions such as who responds and how perfect should that initial response be are questions that we should answer. The third is that there is value in providing information to busy clinicians and global and public health practitioners who possess the skills should be ready and should be ready to respond to requests for information, even when there is an information vacuum. The fourth is we should teach evidence-based skills to all health professionals, and this is certainly something that we are doing within our faculty, and this can be further leveraged on in the future. And related to that is that the pandemic highlighted the importance of being able to quickly recognize what qualifies as good research, or good quality research, finding good papers that is relevant information within a short period of time given the volume. This certainly proved challenging, particularly as the pandemic matured. And if I can quote a listener, she asked in the end, are we seeing the most important papers? And that was particularly as more robust evidence reviews were also emerging. And then finally, the value of inter and cross-disciplinary collaboration is demonstrated here. And again, another question, how do we foster this kind of collaboration? How do we maintain this collaboration? Or do we go back to work as usual when some sense of normality returns, which is what we did? So when reflecting on the daily briefs, another important question to ask is, what is the value of having people located within academic and clinical departments who leverage on their particular expertise and who span the boundaries of their discipline to provide expertise or inputs or perspectives or just support across the disciplines? And the concept of boundary spanning is borrowed from the business world and is used within health systems research as a concept. And I suppose we can argue that our actions as a team and the brief itself allowed for the Global Health Department, in collaboration with others within the university, to cross the boundaries of the disciplines and to provide support at a time when clinicians required support in order to save lives. So ultimately, the biggest lesson learned is that the value of teamwork within health professions is not to be underestimated. And our students have much to add. And there is room for us as academics to do more to bring the students into the center of our discipline, or our disciplines into our communities of practice. So my final slide is borrowed from my colleague, Professor Peter Nyasulu, with whom we also collaborated with during the pandemic on related work. And in a presentation he did, he stated that the identification of a common enemy, COVID-19, led to the identification of our different skill sets, and we were able to leverage these skills and strengths across our disciplines, and I would like to add across our expertise levels, to work towards achieving a common goal, which is to defeat COVID-19. And we should embrace this approach as a way of professional life if we are to achieve great success. And that is important, and it's important for us to recognize that we should train new, and I would add current professionals, to be able to generate and disseminate knowledge that improves practice and policy. The daily brief serves as just one example of how we were able to fill a gap until we were able to hand over to those who were able to apply far more robust techniques to looking at the data. Thanks very much.
Thank you so much for sharing the work you and the student volunteers and other clinicians have done, Prof. English. It's really a remarkable achievement, and we applaud the work of your team. Again, if there are any questions, please pop them in the chat. I'm going to move to the next presentation, and I'll save your questions for the end, Prof. English. So thank you very much. And now I would like to introduce Prof. Lizanne du Plessis. She is an associate professor in community nutrition in the Division of Human Nutrition in the Department of Global Health. She is duly registered as a dietitian and a nutritionist with the Health Professionals Council of South Africa. She has a field of experience that spans 26 years of engagement in public health nutrition, and she has a special interest and research focus on the environment that affects maternal, infant, and young child nutrition and early childhood development. This includes policy, governance, advocacy, and leadership issues, as well as health and nutrition promotion. She currently lectures postgraduate modules to nutrition students and undergraduate modules to dietetic and medical students. Furthermore, Lizanne provides study leadership for the undergraduate and postgraduate research projects. She is active in various committees, working groups with a link to social impact, amongst others, the Western Cape Government Department of Health Nutrition Subdirectorate for Infant and Young Child Feeding Technical Working Group. So I have great pleasure to hand over to you, Prof. du Plessis, and we are very excited to hear your presentation on COVID-19 and nutrition. Thank you very much.
Thank you very much, Lynn, and good afternoon, everyone. I'm also just going to share my screen. Lynn, can you just indicate that you can see my screen?
Yes, we can. It's beautiful in maroon and white.
Right, and you can also hear me?
Yes, we can, loud and clear.
Super. Right, so I just want to say that there will be a poll towards the end of the presentation where I want to ask you, did you change anything about your food, diet, nutrition situation during COVID-19, during the lockdown period and beyond? But you may want to think about that so long. So while I speak, you can reflect on your own personal nutrition journey during this global pandemic. In the meantime, I'll just reflect on what we saw happening and the reasons why food and nutrition became top of mind during this pandemic. We know that many people lost their jobs, they lost their income and livelihood, and they experienced trauma in many, many forms. And household nutrition security very, very quickly became an acute problem, and we saw that in acute hunger, and I'll speak a little bit about that later on. There was also an intense fear of food and other household shortages, and this led to some people reverting to panic buying, at least those ones who could afford it. And when the news broke that people with NCDs were at high risk of morbidity and mortality from COVID-19, many people then started to rethink their diets, their lifestyles, but also the environment that we find ourselves in, also known today as the obesogenic environment and ultra-processed food environment. Also, some people use lockdown to rekindle their cooking skills and also their love for homemade food, again, those who could afford it. Others may have started gardens or food gardens, but many people were left destitute. One of the first emergency nutrition responses that came up and that I was also involved in was around breastfeeding. So the very first news that broke about COVID-19 and breastfeeding, in my opinion, was fake news, because it was suggested that mothers who are COVID-19 positive should stop breastfeeding, and that or that they shouldn't even initiate breastfeeding after the birth of their baby. So you would want to say, but why on earth did this suggestion come up? And it may have been because of the default memory that we have of a previous pandemic and the hard-hit HIV pandemic that we saw in South Africa. My personal thought at the time was just, please, let's not repeat the mistakes of the past. And lo and behold, there was a journal article published in the International Breastfeeding Journal. Mistakes from the HIV pandemic should inform the COVID-19 response for maternal and newborn care. And one of the authors here, the co-authors, were Anna Koutsoudis from South Africa. So in this article, they said that in low, middle and high income countries, some policymakers and practitioners appear to have given more weight to the risk of SARS-CoV-2 transmission than the consequences of maternal separation and reducing breastfeeding. We saw quite a few cases from the Philippines and China and also from Mexico and Vietnam where infants were being separated from their mothers and where mothers were not even allowed to give their infants express breast milk, never mind breastfeeding from the breast. And also they were denied skin-to-skin contact after birth. And we know that these decisions reduced the infant's access to breastfeeding and breast milk, and these decisions were based on very, very little evidence. So given there was little evidence at the time about SARS-CoV-2, but nevertheless, let's just see why there was this reaction. In 2010, in the same journal, in the International Breastfeeding Journal, there was a thematic issue on HIV and infant feeding, lessons learned and ways ahead. And they concluded that the scientific evidence base warns against hasty dismissal of the evolved benefits of breastfeeding. In future, the global health professional community should be more skeptical of claims about the risks of breastfeeding. In 2020, we stood in the future that 2010 journal spoke about. But yeah, even with the substantial, well-documented evidence that was available on the importance of maternal proximity and breastfeeding for child survival, development and health, as well as the protection that breastfeeding affords to mothers, those mistakes were then repeated. Luckily, the World Health Organization quite quickly published interim guidance on the clinical management of COVID-19, including the care of newborn infants. And these guidance were heavily weighted towards supporting the closeness of the mother and breastfeeding. And it's stated here that the infant should be placed skin to skin immediately after birth, initiating breastfeeding within the 1 hour after birth, keeping infants close side by side with the mother day and night so that exclusive breastfeeding could be supported. These guidance was then also repeated and spread across different regions, this one from the Eastern, Central and Southern Africa. And then, of course, the research publications started streaming in, and it kept on streaming in. And at some point in August 2020, I was asked to do a talk on breastfeeding during breastfeeding week, to the Department of Health. And that was the one time that each and every article that I cited was actually from 2012. WHO and other partners also kept on providing guidance, and they did this in the form of briefs, and they updated their clinical management guidelines. They also produced infographics. And one guidance that I just want to pause on for a while is this one, on the financial contributions or contributions in kind from food and beverage companies. And I mention it here because in the context that I'm speaking at the moment about breastfeeding, it was disheartening that companies that produce breast milk substitutes couldn't let this crisis go by without putting wealth before health again. In our own province, in the Western Cape, we were contacted, and when I say we, I mean the Infant and Young Child Feeding Technical Working Group, and by our Nutrition Subdirectorate. They wanted us to also formulate something around breastfeeding because of the news that broke early on and the fake news that was spread. And being the stars that they are, they produced a circular on COVID-19, caring for mothers and breastfeeding infants, and this was signed off in May of 2020. The key message here was support, protect and promote breastfeeding. The next emergency response that I was involved in was around food parcels. And again, it was from our Nutrition Subdirectorate at our provincial office. And they wanted academics to provide them with assistance around ration scales for food parcels, because they were receiving requests from community action networks and also other government departments like social development around food parcels and what they can advise people to do. So Prof. Rina Swart played quite a pivotal role here, and then some others of us provided practical recommendations to other organizations that supplied food parcels. For instance, Community Chest, Food Forward, the Do More Foundation and Sprouting Minds, who teamed up with One World. And on Sprouting Minds, they are an NGO, and they are headed up by one of our former students, now a colleague. And during the time, they were busy with food parcels in the northern suburbs of Cape Town. I reached out to her and I asked her if they could take our students and utilize them in this global pandemic, so that we didn't have to put our students in spaces where they were at risk or higher risk, but also not to leave them on the online platform to learn on that platform only. And I think the photographs on the screen are testimony to how these students just stepped into these roles, gained skills during a global pandemic, scarce skills, and of course assisted this NGO. I want to come back to the hunger issue that I highlighted a little bit earlier on, and specifically around the NITS-CRAM data. They stated early on in 2020 that child hunger in South Africa declined after the introduction of the Child Support Grant. And even despite the economic recession around 2007, 2008, more towards 2009, I think in South Africa, and the slow economic growth since then, child hunger had halved from around 35% that was reported in 2002 to 16% in 2018. But this pandemic then had reversed many of the gains that had been made during the time that the child grant came into play. And during the next wave, during wave 2, it was a little bit better, but then again in wave 3, they reported that food insecurity and hunger had worsened. By wave 4, they reported that and stated and plead that the government needs to place hunger and food insecurity at the center of the COVID-19 response, which now points to the fact that this isn't an acute emergency response anymore. It had now become a chronic condition, but bearing in mind that malnutrition and issues of malnutrition had been an issue before COVID-19 already. And by wave 5 that they reported on in May, I think this year, they said that unfortunately the statement remains true in wave 5 that food insecurity remains stubbornly high. I was also involved with a publication for World Hunger Day in 2020, where Liesel Engelbrecht and myself asked the question, can COVID-19 be the impetus for change that is needed for food and nutrition in South Africa? And we were saying that, of course, everybody hopes that the world will recover from COVID-19 and that our daily lives will go back to normal. But there is a danger of wanting to return to a normal that is flawed. And that normal that is flawed was that nutrition situation that was already in a crisis before COVID-19. That is the referral to a flawed normal. And we also tried to imagine what it would look like if we could get the same stakeholders that showed us that they could act swiftly and they could act courageously, they could pool resources to fight the pandemic, that they could agree on another target for combat, and that is malnutrition. And if you just imagine, if they could in the same united way decide on the coordination and mobilization of resources to create environments, food production systems and infrastructure in which all humans have an opportunity to thrive, how great would that be? Just also to show that the acute situation around hunger and malnutrition wasn't as acute as we thought, or as it was maybe not thought of. Maybe we knew, but some others did not really think about this because it's not always top of mind. But the Children's Institute published this child gauge around food and nutrition as a topic, and part 2 of this document described malnutrition as slow violence, getting that message home that nutrition is not the acute situation that we saw in COVID only. It has been with us for many, many years, and it's evident in our stunting rate specifically, low height for age in our children, that points to a long-standing undernourishment and poor care and health. With all of this evidence already published before COVID around food, planet and health, and how food is the single strongest lever to optimize human health and environmental sustainability on Earth, we knew this already. And we knew that unhealthy diets pose a greater risk to people's health than unsafe sex, alcohol, drug use and tobacco use combined. We know that without action, the world risks failing to meet global targets and today's children will inherit a planet that has been severely degraded and where much of the population will increasingly suffer from malnutrition and preventable disease. And as I said, this was already published before COVID. So my key message here that I take from what we have seen and what we have in evidence is that government and other stakeholders need to place nutrition at the center, not only of the COVID response, but of a response in general, and because we face it, a recovery response. And my plea is here that with the evidence that we have, with the evidence that we can act on, and with the mistakes that we've made in the past, the only real mistake is the one from which we learn nothing. Thank you.
Thank you so much. That was so great to hear, and it was really interesting to hear how you have contributed with the team to the COVID response around nutrition, especially with regards to breastfeeding and with the food parcels. I'm going to move straight into our next presentation, and if you have any questions for Prof. Lizan, please pop them into the chat. We will do a Q&A after this. But for now, let me move on to our last presenter, Dr. Michael McCall. Dr. Michael McCall is a senior lecturer at the Division of Epidemiology and Biostatistics in the Department of Global Health. He qualified as an emergency care practitioner and is passionate about pre-hospital emergency care and research, having worked as an operational paramedic locally and internationally. Michael holds a BTech in emergency care and an MSc in clinical epidemiology at Stellenbosch University and has completed his PhD in public health. His research interests include evidence synthesis, biostatistics, guideline development, and emergency care. He is mostly involved in postgraduate teaching, research synthesis, knowledge translation, and weekly bio consultations with students. Michael's original background is in pre-hospital care, where he worked as an emergency care practitioner before changing after learning that statistics is the common denominator across professions. He is married to an orthopedic consultant who is twice as beautiful as she is strong, and in his spare time he enjoys hiking and trying to convince his daughter he's not a rideable dinosaur. So with that, Michael, thank you. I hand over to you.
Thanks, Lynn, for the kind introductions. Luckily enough for everyone today, my daughter isn't with me, although if she were, she would be sitting on my lap most likely, listening to what I have to say and wanting to contribute to the meeting. So without further ado, I'm very excited to be the last panelist speaker here, and I think this topic that I'm talking about will really tie in nicely to what Renee and others have been saying around collaboration, specifically when we talk about vaccines and this kind of COVID response that academics need to have. And so I'll be talking about balancing rigor and speed, specifically in the evidence synthesis community. And I'll be giving an overview of how we supported the National Department of Health in producing rapid reviews and guidelines when it comes to informing clinical practice for COVID-19 for policy and practice. And I'll give a quick overview of what we did, some examples of other kind of academic collaborations within the university and beyond, contributing to evidence synthesis in both the demand and the supply side, but also speak a bit about some comments and lessons that we've learned through this infodemic and the infodemic in synthesis as well. So I'm really excited to get some comments from the audience as well later around these topics. So just to say that a lot of these slides draw on others' work and collaborative work, including those from Cochrane South Africa, from the Centre for Evidence-Based Healthcare, from National Department of Health, the Essential Drugs Program, and of course colleagues from the Ministry of Health. This is definitely not done in a vacuum and is very much a collaborative effort. So I think as we go, we know that the COVID pandemic started in South Africa, at least it reached our shores in March, and we're quite all familiar with the story. but the problem was that specifically when it comes to decision makers and clinicians is that they required trustworthy evidence to inform treatment decisions. And when we talk about the infodemic, we also, in the evidence synthesis community, talk about this massive explosion of trials, of COVID-linked trials and research that it just becomes insurmountably large for us to try and figure out what is the best evidence to use. We want to make clinical decisions at a public health level. And so the South African National Department of Health, through its ministerially appointed National Essential Medicine List Committee, urgently needed trustworthy information to inform guidelines on how healthcare workers should treat people with COVID-19 and prevent others from contracting the disease. And as a result of the rapid spread of the virus and the global sense of urgency to find effective medicines, especially in the beginning of the pandemic, and even today, information was really at a short supply. And there was almost later down as the pandemic progressed, too much information, and it became very difficult to answer the question about what should we use to inform policy and practice. And so what we did together with National Department of Health is we developed a process of in the existing systems to support best evidence synthesis to provide recommendations for National Department of Health. And so this was a partnership between NEMLAC and the South African GRADE Network, which is a group of specialists that work around evidence synthesis, Cochrane South Africa, and the Center for Evidence-Based Healthcare. And these two groups came together and produced what's called rapid reviews, which is essentially a systematic review that's done in the context of an emergency or an urgent request for information or evidence regarding a particular issue. And so these are done within 7 to 21 days, where typically a systematic review would take years to complete. These reviews, because it's in an emergency situation and such urgent information that's required, is done in a rapid manner, in a rapid turnaround time, but still trying to balance rigor and speed. And these reviews then would inform national decisions and guidelines through the Therapeutic Guidelines Subcommittee for COVID-19. And so when it comes to kind of a bit more deeper around the review process, and it really linked to and drew on the emerging evidence around how we conduct rapid reviews, which is really spurred on by the pandemic. We drew on the Cochrane Rapid Reviews group methods on how to conduct these reviews. But essentially, we mimicked a lot of the key characteristics of systematic reviews, and they were key principles that guided this process, including transparency, avoiding bias, avoiding selection bias, asking clear and robust questions, using the PICO format and all those kind of things, good governance and good systems, a clear consensus process for when we present evidence to how that moves to a recommendation so that it's not in a black box or what's called a gobsat, a good old boys sitting around the table, but that decision from evidence to a recommendation to policy and practice is a clear one. And of course, how we're going to update this evidence and how it evolves over time. And I'm not going to go into detail about how these rapid reviews were developed, except to say that it's drew on the existing processes around how we conduct rapid reviews, and that it's both a balance of rigor and speed. But these can be easily accessed on the COVID-19 National Department of Health website. And so a question that I have for the audience is, how many of you are aware of this website around the guidelines that National Department of Health has produced? It'd be great to see in the chat whether you're familiar with these rapid reviews that has been produced, and I would advocate you to have a look at these. They are really the cutting edge and up-to-date guidance and reviews for that has been produced. And so to date, we've produced almost 42 reviews, which include up to 23 updates. And these include reviews on ivermectin and colchicine and all of these medicines that come up as potential treatments for COVID. And I see some of the members in the audience also have contributed to these evidence syntheses, which is fantastic to see. So, I mean, when it comes to vaccines and all that, I was also lucky enough to be involved in the AstraZeneca and Sinovac review for the vaccines, and it had a very similar process to what's being described now. But essentially, you can see some of the recommendations that have been made, and these are all easily accessible on the website at the National Department of Health. So a question that we have and we need to consider when we are looking at vaccines in the COVID world is where rapid reviews and evidence synthesis kind of sits in the evidence ecosystem. And this slide is really just to say that when it comes to making public health decisions, we move from the step 1 in this slide, which is looking at primary evidence trials and so forth, and we synthesize that in step 2, typically through a systematic review, which eventually inform guidelines, which take in consideration not just the evidence, but acceptability, feasibility, equity, cost effectiveness, and those things. And eventually it moves down to dissemination to policymakers, clinicians, and completes the cycle. And this is kind of an ideal picture of how it works, but we know in COVID there's been so many challenges that researchers and academics have been faced with, including the massive amount of primary evidence that we have to deal with, the trouble and the immediate need of having to produce synthesis at such a high and intense speed. In other words, doing synthesis at step 2, not over years, but over days, means that it's very intensive and you need experienced teams running on the ground to get started. But of course, in the pandemic and what we're talking about today around this infodemic as well, a lot of the gap and challenges is around how we move from steps 3 to 4, from using high quality evidence and guidance, and how that translates to the person on the ground, or the people on the ground. And it's fantastic to see what other presenters have done around moving that evidence to the people that need it. And so there are many challenges we have to deal with, but there are also many victories that I think we can celebrate in academia around the fight against COVID and misinformation. And some of these specifically speak to what Renee and others have spoken about around collaboration among people and academics across generations, across disciplines. And in the evidence synthesis world, there's been some great moves in building evidence synthesis infrastructure. So this is repositories, for example, of COVID-19 evidence that Renee and others would be able to draw on to inform clinical practice and policy in clinicians for summaries, like Love Epistemonicourse or the Cochrane Registry for COVID trials. There's also evidence synthesis coordination efforts like COVID End that have been produced. For example, supporting the demand of evidence and the supply of evidence side, which is essentially supporting evidence synthesis networks by reducing duplication of effort. And I would advocate people look at the COVID End website as a point of entry. And then, of course, the emergence of living systematic reviews that are continuously updated on a weekly or monthly basis, and websites such as COVID NMA, which really set the bedrock for how clinicians and decision makers can access information to come to the best treatment recommendations for COVID. And of course, speaking about recommendations and guidelines, there's been some fantastic work around inventories of guideline recommendations, which members in our countries can be adapted locally to be used, which is fantastic. So here's a quick screenshot on COVID NMA, a living inventory of all the treatment trials in COVID, a massive undertaking, many collaborators across the world pooling their resources, pooling their manpower, human resource power, women power, whatever it may be, together to combat COVID. And it's a great initiative and a source of evidence that helps reduce duplication of effort when it comes to finding and using evidence. Again, there's an inventory of existing recommendations for COVID, which I think is a fantastic starting point for committees who want to look at, and governments who want to look at using existing recommendations and guidelines that are high quality and relevant to adapt or adopt it to their setting. And so here you can see a screenshot of, for example, the guidance around ivermectin and the consistency of the message across guidance groups. And the nice thing about this is it has a lot of metadata in the background that committees can use, such as, for example, the National Department of Health here in South Africa. And we've been drawing and feeding into this collaboration globally. And I think one of the main messages that I want to make today, and there's 3 of them, is one, is we don't need to reinvent the wheel when it comes to making decisions about what is the best treatments, or how we go about creating guidance for the best treatments for COVID-19. We need to, at a point of entry, start looking at systematic reviews or high quality guidelines that are relevant to our question that we're asking. And so COVID End, and this was a project led partly by Stellenbosch University and Prof Young, together with others from the COVID End Working Group, international collaboration, put together a resource around how do you go about developing new systematic reviews without reinventing the wheel. And there's an entire PDF in the background linked to this website that takes you through essentially developing a review, a systematic review, without replicating the wheel or reinventing the wheel. So drawing on existing reviews first before starting something new. And then I think something to say, and linked to what others have already said, is that there are many different ways of doing reviews and evidence synthesis, as this table kind of indicates, and it's very busy, so no need to actually look at it. But the main message is that it's a collaborative effort. And in the effort of not replicating the wheel and producing high quality studies, I think it's essential that we have a collaborative approach in any research we do. From method to content expertise to including patient representatives with an equity lens in the research that we conduct. And then I think another point that I want to emphasize today, looking back at the research that we have done and the research that is ongoing globally, is that when it comes to NMICs and academics, we are the untapped well that can truly contribute to combating COVID-19 in NMICs where the burden and inequity is the most vicious. And so when I say we, it's really NMICs that I think through collaboration and acknowledging that we have the expertise to contribute to the evidence journey and ecosystem, I think that's essential to recognize our capacity there. And secondly, to build capacity in evidence synthesis locally. And into that, Stellenbosch University is also leading in that front in equipping clinicians and policymakers to find, use and interpret systematic reviews of effect through short courses and master's level modules. And then lastly, to say that when we produce evidence and even evidence synthesis, I think we would be very much, especially in the times that we are now, be held at fault if we do not include a clear knowledge translation activity in any research we do. It is all too easy to produce research that is potentially a breakthrough, but it has no follow through. In other words, we might publish something, but it stays there. And I think that's a significant problem that we need to fundamentally think of as a paradigm shift. When we produce research, it is not enough to publish it. We need to move to including knowledge translation strategies, specifically looking at the logos, the ethos, and the pathos. So not just the evidence that we use to persuade people, as Aristotle said, but including a clear description of the grand narrative that it fits into, and being clear about who is communicating that message. And I would argue that ethics committees need to screen that a knowledge translation plan is in place for any research that is being conducted. This is, of course, difficult for systematic reviews because it typically doesn't go through an HREC process, but I think we need to make a paradigm shift, specifically if we want to be at the forefront of combating the misinformation that is being perpetuated because of cherry picking of research. So that's it from my side, and just to say thank you very much for being here, and looking forward to the conversation moving forward.
Thank you so much, Michael. That was really interesting. I really love your graphics. Were those yours that you created with the team, or are they from other articles?
The algorithms, Lynn?
Yes.
Yes, so some of them are from myself, and some of them are definitely from teams and collaborators working together.
You should maybe you can send us the people who are associated with those, so that when we share them on our Twitter chat from today, we can tag the relevant people in it, because I have a feeling it will be shared because they are really useful and easy to use.
Sure, we'll do, Lynn.
Thanks. Well, everybody, that brings us to the end of the presentations. Thank you so much for to the presenters for those really interesting and thought-provoking sentiments that they shared. We have questions in the chat box, and I wonder if at this point the presenters wouldn't mind putting on their videos so that we can have a conversation with one another. I've tried to put the questions into the chat box so that you have time to look at them. So Prof. Renee, perhaps we can start with you. And I see Anke has asked a similar question. How did you determine what the most important papers were when you were sifting through all of the information?
So, you know, initially, as I said, it was simple. There was just nothing on COVID, and every single paper that came out was useful. The papers that did come out initially, mainly from China and then from Italy, you know, as the pandemic spread, and from South Asia, etc., were primarily retrospective studies looking at clinical data, patient data, looking at clinical outcomes, clinical characteristics, risk factors, etc. And it was very interesting tracking those papers with the different, for example, requirements for categorizing patients who are at risk or at high risk, etc. So it was really interesting at the time to see how the data was starting to inform not only diagnosis, but also treatment of patients and management. And so with that came radiographic data, and then treatment and management data started to emerge, and prone, for example, ventilation of patients, not, you know, that's, and use of oxygen, etc. It was as the pandemic matured, and this is where I will pick up on what Michael said, and there was just this explosion of data, of papers, all sorts of papers emerged, systematic reviews, rapid reviews, whatever you can. Some clinical trials also started to emerge, and that's where it started to get complicated. And we were trying to also engage with Taryn in the process, who was now starting to feed some of the websites that Michael was referring to, or initiatives, feed it back to us and say, you know, go to this website, go here, go look at this group, etc. And as I said, I started to take a step back in terms of the nitty-gritty of this project towards the end. But on chatting to Elisna again, you know, as I was preparing for this presentation, she just, you know, reiterated that it was that very challenge of sifting through the papers and the data, trying to find the good quality evidence, that then led to the realization that you know, there's enough data out there to inform practice, and the clinical guidelines teams were organizing themselves. National department had become sort of the authority in terms of approaches to take, and so it had matured. And I suppose we don't reflect enough even on that process and how it happened, and that we just stepped back eventually because there wasn't, as much as there was a need for the daily, and that speaks to the second question that was posed in the chat, but there were other more robust, far more robust ways, and yeah, and it was led by people whose expertise this is. To answer the second question around innovative ways of assisting those in the front line, you know, again, this whole process has made me realize that we've kind of just moved on to the next thing and haven't really sat down and reflected on much of the value of this kind of knowledge translation activity that we engaged in. And so I just scribbled down a few thoughts, and Anke mentioned that in another chat, but the challenge is balancing rigor and speed. And I think that's the first thing, is wading through the evidence. The second is, and it again picks up on very similar things that the other speakers spoke about, it's about having a team, and it's about having people who are committed, and you need time to do that kind of thing. And when you are busy doing everything else, in the moment of the crisis, when you are not doing your usual daily work, this becomes easy to do. But when life normalizes, it was very difficult. But it does link to being able to, and this also came up in the discussions, is pointing people to the correct sources and the correct information and showing them what is available and helping people to identify good research. And that comes to the capacity building, etc. And I would also hazard a response that we should be needs-based and we should respond to questions or provide evidence that will have a high impact in terms of practice for the frontline clinicians. Of all those things, I think the thing that worked the most was asking the practitioners, what is it that you need? And giving them exactly what they need. They want evidence on this, and that's what you feed them. I, on reflection, think the WhatsApps or that way of sending information simply did work. Thanks.
Thank you very much for that, Renee, and thank you for responding to the follow-up question around the innovation. Perhaps we can move to Michael's question, because Renee did mention some of that in her response. Anke's asked what the turnaround time was for the rapid review, and how did you balance the rigor with the need to get the results out ASAP?
Yeah, that's a fantastic question, and one that is still up in the air mostly for evidence synthesis around rapid reviews, specifically living reviews. But so essentially the turnaround time varied from one review that I was part of, which was 3 days and 2 weeks to a month. So, but typically the rapid reviews we conducted for the Department of Health was about a week or two. That was the timeline we had for these reviews from start to finish. And I think the important thing to note is that regarding a process of how we did it, we still had all the steps of a normal systematic review, except that at particular key steps, for example, finding comprehensive randomized controlled trials to answer a question, we drew firstly on existing evidence repositories, like, for example, that is being put forward at covidnma.com, which is living reviews. So where living reviews already existed, we drew on that evidence summaries and meta-analyses and grade summary of finding tables to inform our rapid reviews. And where their searches, for example, weren't up to date by the week, we updated those searches and screened and went through that process in a slightly more rapid manner, and eventually resynthesized that information back into the review and presented that to NEMLAC via an evidence decision framework. I think what's key here is the use of GRADE and the fantastic efforts of the global evidence synthesis community to also gather around GRADE and the quality of evidence mechanisms that's fed into the existing mechanisms of National Department of Health. I think the other thing to note is that I don't think rapid reviews is something that will be done, that should be used for making as a new method for systematic reviews. It should only be used in the context of emergencies and urgent response to information. So I wouldn't advocate doing a rapid review as part of your master's. I would do a systematic review. Yeah.
Thanks, Michael. Michael, just for interest's sake, how many people would be involved in one of those rapid reviews that you were doing?
Yeah, so typically you'd have in the setting that we were working with, you'd have the NEMLAC committee, which is a bunch of experts, really, and content experts. But then you'd have 2 or 3 key methodologists who have experience in doing systematic reviews that lead the process, the review process. So I would say you would have a team of about 5 to 10 people on average, that from a variety of disciplines and expertise that all feed into this mechanism of producing a rapid review on such a rapid turnaround time. And that's fantastic to see that the collaboration that occurs.
Yeah, thanks so much, Michael. Prof. Lizon, can we move over to you? So I've popped some questions into the chat box. Just, in terms of how do we prevent this mistake from happening again, where we have evidence and then the guidelines, the practical guidelines are changing daily, even though the evidence was existing to begin with?
Thanks, Lynn, and yeah, thank you for the questions. So I think often I feel that because people eat every day, they think that they can make decisions about nutrition without consulting evidence. That's unfortunately so. And we have a quote that we often use in teaching, is that nutrition is everybody's business, but nobody's responsibility. So somebody has to take responsibility here, and you can't just throw evidence out of the window when it is something that you do every day, a practice. All of us eat. And then when it comes to applying evidence, then you give everybody a chance to give input and also fall back on personal experiences and all of that. So of course, no experience is should be disregarded, especially in our healthcare system. But I think we see too much of that. When nutrition is not given its rightful place, and where the evidence that has been built over so many years is not embraced. So that is just, on the one hand, it's sad that that happens, and that it happens up to today. So how do we prevent this from happening again? I think we should be advocating for nutrition and specifics in nutrition. In my case, I try to focus my attention and my efforts on infant and young child feeding, breastfeeding, of course, within that, and also maternal support. So we shouldn't forget the mother in all of this and just push the feeding for the infant, for instance. But in saying that, I often also say, if mothers know what is not in formula, for instance, so if we swap questions and we don't just punt breast is best, breast is best, we look at this from a different perspective and concentrate on issues around what is missing in formula milk. Then mothers will be, maybe a different kind of awakening will happen around nutrition and infant nutrition specifically. So I think sometimes we don't frame our questions correctly, sometimes we don't frame our messages correctly, and we have to be very aware of that. What do the public understand, and how we should be communicating more effectively? In saying that, not only to the public, but also to policymakers, so that it's very clear what the evidence is. And I mean, there are many different questions that go through my mind, and also opinions that we do have around why isn't nutrition top of agenda? They say that it's top of agenda, but we don't see it. So yes, everybody says and they recognize nutrition is important, but I almost feel that the efforts are not focused on nutrition. So if you really say that nutrition is top of agenda in your country, then that must be followed with budget. It must be followed with resources. That is how it works definitely in the government system. So why aren't we seeing that? We have beautiful policies, they are evidence-based, but when it comes to implementation, we are failed in our country. So we have tried to get it higher up in government. Some aspects of nutrition is situated right up in the presidency, but still we have distractions. I call it distractions in our system and also in our country. As soon as something else comes around, if it's not drought, then it's electricity. If it's not that, it's COVID. There's always something distracting us from focusing on getting that one thing right. So my life mission, my professional mission is to keep on advocating this message until we get there, where government will say, right, okay, we actually need to put our money where our mouths are and also get a focused approach so that we focus on one thing and not try to distract our attention to too many things. Sorry, long answer.
No, it's fine. And I think that is your key message, is to get rid of the distractions, focus on nutrition, center nutrition in what we are doing, and then also to look at what is available and to get the message out to all stakeholders to make this happen. And I think that's what Renee's follow-up question was about, is, how did those on the front line react, and what did they say regarding to be able to change practice with regards to breastfeeding during the pandemic? I remember when I was in hospital with a little one, every day there was a new notice or circular that came around. Okay, now you're allowed in the ICU. Now mommy and daddy can go. Now only mommy can go. Now you can only go for a few minutes. But every day we got a new notice. So what were people on the front line saying about these changing guidelines? If you can just in 1 minute, I know it's very short, perhaps try to respond to that question, please.
Yeah, so I think the message did come through. Unfortunately, at the front line, it wasn't always practiced. Again, it was not based on evidence, all of the practices, but it was based on whatever was happening in that ward, maybe even before COVID. What we do know is that for some, lockdown was actually a saving grace. They could be at home with their babies and they could continue breastfeeding. The workplace issues that some people face were not necessarily deterring them from breastfeeding because they were at home. So there were mixed feedback that we received. But I think as long as we take this and we learn from the mistakes that was made here, and we will have other emergencies coming up in future, but we should just apply that and go to the evidence again, and not just pluck something from the air that you think will work for nutrition.
Thank you very much, and I think that's a great key message and closing statement from you, Prof. du Plessis. We really appreciate that. If I could just quickly hand over to Prof. English and then Michael, just as your closing statement on this topic. We have about 3 minutes remaining, so if you could share that time wisely with one another and myself. Thank you.
Okay, thank you. I've just got two closing points. The one speaks to what Lizanne said. Now, I often feel that there are many health-related issues that are measured in health, but the responsibility for that lies elsewhere. And so the other sectors don't take responsibility for that because they don't need to be held accountable for it. So malnutrition, stunting, it's all, the health is asked to account for that. And I think that's one of the problems. The second is that, yeah, I have many things to say in conclusion, but I do think that the change has to come from inside, and we need to start at undergraduate levels in our postgraduate programs, in how we train our health professionals to do all of these things that we are talking about, including to combat misinformation. Thank you.
Thank you so much, Renee. Michael?
Yeah, I mean, just to focus on what Lizanne and Renee is saying is we are the untapped well. We have so much to offer in this setting, and I think that we must put up our hands. So I want to encourage the audience. I want to encourage those that are listening online or on Twitter to put up your hand and contribute to the work that the global community is doing, and to develop your capacity. So don't be afraid to put up your hand. We have all put up our hands, and I myself was apprehensive in the beginning. I'm not a virologist. What do I know about COVID? But we can all contribute as a global team and collective towards eradicating COVID and re-establishing the status where we want to be again in South Africa. and beyond.
Thank you so much. I think this is the best panel. We are finishing on the dot at 4:15. Thank you very much for your inputs. This is recorded and it will be posted onto the, I think, to the YouTube channel, Tracy, and we will put the links onto our Twitter feed and to the center's website. But we thank you so much on behalf of the Department of Global Health and Stellenbosch University for this really interesting talk around innovation, collaboration, and working with different stakeholders in getting the messages across during the pandemic. So thank you so much to our panel members and to the audience who have joined. We look forward to carrying the conversation forward on Twitter and on our Facebook page. Thanks everyone. Have a good rest of the